like to go back and take a look, reference it. And the purpose here is to give Timothy some feedback before he goes into the lion's den among friends before that big day comes. So if you have constructive feedback, feel free to put it in the chat as we're going through. We'll have a few minutes to discuss some key points at the end. And of course, you can always contact Timothy as well as most of us on the Teams channel for GEMINI. So I think without further ado, we are ready to go ahead and get started. So I will turn it over to Timothy. Karibu, Timothy.
Asante, Ashley. Yeah, thank you, everyone. So my name's Timothy Plus Peter, and today I'll be practicing my thesis defense here at KSMC, and I'm present to you. I expect to have some feedbacks from you. Yeah, so this is my title, the association between provider shift timing and the clinical outcomes among traumatic brain injury patients at Kilimanjaro Christian Medical Centre, MS Medicines Department. And this study has been designed as a retrospective cohort study. So these are the outline of my presentation. I'll go through the acronym, definition of terms, up to conclusion, recommendation, and acknowledgement. So this is the list of acronyms for which many of you are aware of, that I'm going to use them during my presentation. So this is the definition of terms. The TBI, what does TBI mean? TBI means the traumatic brain injury, which is an injury that affects how the brain works. And GSE, Glasgow Outcome Scale, that is a tool used to assess the outcome of a patient after severe brain damage. It ranges from 1 to 8, whereby 1 is death, and along up to 8 is a upper good recovery. And GCS, this is a Glasgow Coma Scale, is a scale that is used to describe the extent of impaired consciousness in all type of acute medical trauma patient, and it's categorized into 13 to 15 as a mild, moderate is 9 to 12, and severe is 3 to 8. So operational definition. So what does provider shift timing means? This is the time at which the TBI patient arrived at the emergency department, and it's based on the healthcare provider that he or she is scheduled. And KSMC healthcare provider operating in 2 main shifts, the day shift and the night shift. The day shift is starting in the morning, and it's running to evening. And it's starting to 80 hours to 200 hours. And the night shift is started from 200 hours to 80 hours. So to account for time that we are doing the patient handover and reporting, we consider the day shift to start from 730 hours to 2029 hours. And the night shift from 2030 hours to 729 hours. And the clinical outcome means the favorable or unfavorable in hospital outcome. And in this study, the hospital outcome will be measured within 7 days, and it will be measured by using Glasgow Outcome Scale extended. And this score has been dichotomized into 2, unfavorable, which for those patients who score 1 to 4, and favorable good outcome for those patients who score 5 to 8. So in the background, we know that 69 million people in global experience TBI from all causes. And in comparison, those patients who experience TBI in sub-Saharan Africa, they have worse outcome in compared to those patients who experience TBI in high-income countries. And it has been reported that a significant number of lives can be saved by improving trauma care globally. And the emergency as a growing field, it has been presented with the challenges like resource allocation, reducing staffing, and delayed intervention. So the problem of the statement, so TBI burden is manifested throughout the world. And the low middle income country, we have resource constraint to address their associated outcome due to TBI. And mortality due to TBI in KSMC for patients with severe TBI in KSMC is approximately 50%, for which there are also other hospitals in Tanzania which have mortality higher than that. So there is a mixed evidence in the literature that have studied the influence of provider shift time on patient outcome, which some studies they show significant findings, other they show non-significant findings. So in this study, we aims to investigate the association between EMD provider shift timing and outcome among TBI patients. This is my conceptual framework. So I focus on traumatic brain injury patients. I assess the provider shift timing or the working shift from day shift and night shift, for which is my main exposure. I associate with the outcomes, and this association is confounded with the following variables: the age, sex, comorbidities, mechanism of arrival, intention of injury, substance use, presence of multiple injuries, TBI severity, mechanism of arrival, and surgery. So also in this variable, they associate to each others, like age is associated with mechanism of injury. Like younger adult, they have more road traffic injuries as compared to the elder people, as they have fall. Also for the sex, the majority of male are the one who have injuries. Also, comorbidities is associated with surgery, like for those patients with comorbidities like hypertension and diabetes, they have to wait to be controlled for the hypertension to be taken to surgery. So there are variables here, they are correlated, others they are not correlated. Also, this conceptualization is done by taking into account these potential confounders to assess the effect of EMD arrival time or provider shift timing of day and night shift to the patient outcome or discharge within the 7 days. Also, this is the justification. So this study is going to help to improve clinical process and care, and also will be as a quality benchmark for the emergency care in Tanzania, and it's going to inform strategies to optimize staff to patient ratios. So research questions. What is the proportion of TBI patients arrived at KSMC emergency department during the day shift and night shift from January 2020 to December 2024? How do the probability of good outcome differ between TBI patients arriving during the day shift and those arriving during the night from January 2020 to December 2024 at KSMC EMD? And what is the relationship between provider shift timing and the clinical outcome among TBI patients from January 2020 to December 2024? And these are my objectives. So the broad objectives to determine the association between provider shift timing and the clinical outcomes in TBI patients at KSMC EMD. And specifically, I have to determine the specific number one, I have to determine the proportion of TBI patients who arrive at KSMC EMD during the day shift and the night shift from January 2020 to December 2024. And number two is to estimate the probability of good outcome for TBI patients arriving during the day shift and those arriving during the night from January 2020 to December 2024. And I have to investigate the relationship between EMD provider shift timing and the clinical outcome among TBI patients at KSMC emergency department from January 2020 to December 2024. So these are my methodology. So methodology of the parent study, I use the KSMC clinical trauma registry study. And KSMC clinical trauma registry is using questionnaire as a tool for data collection, and data stored in the red cap survey, and data collected from when patients arrive until discharge. So this one is allowing this registry to be used for cohort and prospective studies as well as for retrospective studies. So data collection is done by trained research assistants. So methodology for the current study. This study is designed by using retrospective cohort study design by using data from KSMC clinical trauma registry, and there's data from January 2020 to December 2024, and the study area is KSMC hospital. For the study variable, for the dependent variable, I have poor outcome at discharge as my dependent variable, and this is determined by use GOSE. And independent variables, I have a candidate variable, which is exposure, which is my main exposure variable as arrival time during the day shift or night shift. I have patient characteristics as a to control for that, injury characteristics and the clinical care needs, which they have been determined by using the KSMC CPG clinical practice guideline, like need for CT, the need for fluids, need for CT scan. So statistical analysis, I did the statistical analysis by using R statistical software version 4.21, and I assessed for the pattern of the missingness, and the complete case analysis was done. For the data summarization, I summarize categorical variable by using absolute number and percentages. For continuous variable, I summarize it by using median data quartile range. And I present for the survival probability, I use Kaplan-Meier survival curves, and also I use narration and tables to present some of the findings. So to understand the survival probabilities across EMD shifts, I use log rank test to test for that. For categorical association, I use the chi-square. And association between EMD shift and poor outcome, I use the crude and readjusted Cox regression model. And also I tested for the model assumption, including proportional hazard, multicollinearity, linearity, and influential values. So for the proportional hazards, we found that variables like surgery, mechanism of injury, presence of other injuries, and comorbidities, they violate the proportional hazard assumption. And I use the stratified Cox as a measure against the violation. Also, I checked it for multicollinearity, and I found that I declared that there is no collinearity because I didn't have VIF of greater than 10 in my data set, in my variables. Also, I checked for the linearity and influential values. So I also did the model selection, and I compare between Weibull model and the Cox regression model by using the archaic information criteria. So as we see, the Cox regression model is having the lowest AIC, and that makes me to use the Cox regression model in my analysis. So the study participants, the inclusion criteria, I include adults at least 18 years and above who have an acute injury that occur within 24 hours, and exclude patient who miss information arrival date and time. So this is the patient enrollment flowchart. As KSMC trauma registry is involving all the patients, I exclude the patient who doesn't have TBI, and those patients who have missed information on EMD presentation time. And I remain with this 1,211 participants on my final analysis. And I did the power calculations, and I found my studies having power of greater than 99%, which is enough for me to detect this association of EMD arrival time and the outcome for TBI patients. So these are my results. So I found out that 60% of the participants are arriving during the day shift and 40% during the night shift. And 48.6% of my participants have poor outcome. And in my sample, majority of my patients have had mild TBI. So to compare to estimate the survival probabilities for the patient who arrive during the day and night shift. So you see in the y-axis here the probability of good outcome or probability of being free from poor outcome. And on the x-axis, as you can see, this is the follow-up time, which is 168 hours, which is equivalent into 7 days. As you can see, the survival probabilities or probability of good outcome is decreasing over time. And those patients who arrive to the EMD during the night shift have higher probabilities of good outcome compared to those who have arriving during the day shift. And you can see here the p-value from the log-rank test is statistically significant, which is show that the arrival during the night shift differ in terms of outcome for these TBI patients. And I did the stratification with the severity of the injury, because outcome differ depending on the severity. So you can see For the mild TBI, the outcome is marginal significant. The stratification between the day and night shift is marginal significant, but for the moderate and severe TBI is not marginally significant associated. When we come to test the association between the EMD arrival time or shift timing on the outcome by using the crude and adjusted Cox regression model, as we can see in table 4. So we have shift timing as our main exposure. As you can see in the crude model, those patients who are arriving during the night shift have the lowest hazard ratio, 0.6 times less than those who are arriving during the day shift. And this was marginal significant. But in the adjusted model, with those variables we see here in this table 4, and the stratification with surgery comorbidities, presence of other injuries, and mechanism of arrival. But we can see the estimate here due to stratification due to stratified Cox. We see that this association is no longer significantly associated with the arrival time is no longer associated with the outcome. So in discussion, so as you can see from our findings that 60% of the TBI patients present to the KSM-CMD during the day shift. This is similar to the study done in Malawi and in Asia. And this is in contrast to the study done in South Africa. And that's found that 60% of the injured patients arrive during the nights. I think this is because of the intentional injury and interconflict that happened during the night that made patients come during the night. But also, for the 60% of the TBI patients, they arrive to KSMC during the night shift. This is due to the reason that also injuries occur at random. Also, for those patients who have self-referrals, their arrival time is random also. Also, this also you can see there are studies that have shown that the presence of many patients arriving during the day or night time with the presence of emergency physician, they can manage those patients and they can't affect care for the patient, regardless of the volume of the patient at that time. So as you can see also the good outcome probabilities from Kaplan-Meier survival curves for patient arriving during the night shift with p-value, with the significant p-value. This is similar with the study done in Netherlands, but this was unexpected. And the reason of that is the transfer advantage for those patients arriving during the nighttime in the Netherlands. So as you can see also there was no significant association between arrival time at the EMD report come among TBI patients. This is similar with the study done in Denmark and is different to contrast with the study done in Netherlands. I think this in KSMC, the reason for not having EMD arrival time not be associated with the outcome. This is due to the specialized care provision at KSMC and also system improvement in terms of there is a registry, like a trauma registry, with a clinical practice guideline to treat TBI patients and capacity buildings to train EMD physician, as well as infrastructure changes at KSMC over time. So the strength and limitation of the study. This study has the following strength. It addressed the critical knowledge gap of association between EMD arrival time and outcome. And this study employed the robust analytical method by using Cox, the stratified Cox regression model. And limitation of this study is the use of the secondary data, which limits to control for everything. Also, there was ability to do a study in a single center makes make it hard to generalize in the broader population. In conclusion, we see findings from this study show that majority of TBI patients arrive during the day shift, and we see no statistical association between patient arrival time and in-hospital outcome after adjusting for potential confounders. And this is portray consistent quality of care regardless of time of arrival at the EMD. And this study highlight the need to address those remaining gaps to reduce injury-related mortality, so that to be together with the global targets. So the recommendation. So we recommend to optimize hospital process to ensure efficient patients and minimize congestion, overcrowding during the peak hours. Also, there is a need for a systematic evaluation, or to do evaluation on the effectiveness of those innovation in terms of human resource and capacity building, in that if they are the one which contribute to the lower mortality rates or poor outcome for TBI patients. Also, as we need to further research is needed to investigate underlying drivers for poor hospital outcome among TBI patients, especially to focus on gaps in pre-hospital care, because we see after we adjusting this association was significant in the code model, but after adjusting with the other clinical and demographic characteristics, it was no longer significant. So this maybe it is associated with the pre-hospital care and not in hospital care. So and also this gap also can help to study it in the national context. We can also do the same study in the national context, so that to improve the EMD care nationalized. Thank you, everyone. Welcome for questions.
Awesome. Thanks so much, Timothy. I'm going to stop